Facilities that make this program possible are provided by the City of Highland Park. Programs are produced independently by members of the community. The City of Highland Park is not affiliated with the following program or the producers of public access programming and is not responsible for the content. The following program does not reflect the opinions of the City of Highland Park.
Welcome to another edition of Chill Out. I'm Pam Chill, one of the Highland Park senior producers, and today's program is about the diagnosis and the treatment of varicose veins. I am very honored to have today my distinguished guest is an expert in the field of varicose vein treatment, Dr. Stephen Humphrey. Welcome to my program. Thank you so much. It's been a long time I've wanted you to come here and speak about varicose veins.
Thank you for inviting me.
I'm
happy to be here.
My pleasure. We're going to go through a lot of material. First, I do want to do a brief biography on you. You graduated with your MD from University of Texas Medical School, School of Medicine in Houston. Thereafter, Dr. Humphrey, you completed your residency in diagnostic radiology at Boston University School of Medicine in Boston. And you then completed your fellowship in cardiovascular and interventional radiology at Massachusetts General. You are double board certified in both diagnostic and interventional radiology. And prior to joining Vein Clinics of America, Dr. Humphrey, you were medical director at St. Michael's Hospital and Wheaton Franciscan Healthcare, Brown Deer in Milwaukee, which is where you reside. You were talking about that. And you were previously an interventional radiologist at St. Francis Hospital. Most recently, you were interventional radiologist as well as president and CEO of Radiology Specialists of Milwaukee. So tell me, so you're practicing right now, you said,
Correct.
in Gurnee?
I have an office in Gurnee, and I also have an office in Buffalo Grove and in Schaumburg.
Okay, excellent. And you also underwent extensive training in phlebology, the diagnosis and treatment of varicose vein disease, and all related disorders.
That's correct.
Yes. So tell me, how did you get started in the field? What initiated when you went to medical school that you decided this is a specialty that you wanted to undertake?
Well, I was very interested in radiology, and then once I got involved in radiology, I decided that I wanted to be a little bit more involved in patient care. And there's a very specialized portion of radiology where we use imaging, CTs, ultrasound, MRIs, to perform a variety of procedures on patients, such as biopsies or placing ports for people that may need chemotherapy, working with people's dialysis grafts and dialysis catheters for access. And sometime in the 2000s, the introduction of the minimally invasive treatment for varicose vein disease was brought into the United States. Prior to that, varicose vein disease was pretty much treated by surgeons. It was a surgical procedure. And when this new minimally invasive procedure was brought here to the United States, that's when I became interested in treating varicose vein disease.
How long has it been that it has been minimally invasive?
It's been minimally invasive since the mid-2000s. Although I have to admit my mother has varicose vein disease, and I had already started treating these veins minimally invasively whenever she first got diagnosed. And I couldn't treat her because Medicare didn't pay for it at that time. So it was probably 2011 before Medicare really started paying for these minimally invasive treatments.
That's really a very short time when you think about it.
It's a very short time.
Right. You know, because so many people have it. So tell me about, on varicose veins, what cost, besides loss of work and hospitalization, or, there are different degrees of it, but what cost does it to the actual patient and to the public?
Well, varicose vein disease is a complex disease. It's really, the disease itself is really called venous insufficiency, and varicose vein disease is kind of what occurs when you have venous insufficiency. But it, you know, a lot of people get this, a lot of women get it. It obviously, most people think of the cosmetic consequences of it first because you see the big ropey veins. But the symptomatic piece of it is it just makes your legs tired, can make them painful, can cause people to miss work. I think the cost, you know, to society is relatively large, and it's a very underdiagnosed and undertreated problem.
Tell me about the types of conditions that would necessitate treatment, the different professions, or does hereditary play a factor in it?
Well, venous insufficiency is a little bit more common in women when you're younger, partially because of pregnancy. If you wait and look at people that are about 80 years old or so, you would have pretty even distribution between men and women that would have the disease. But other things that can kind of add to the probability of getting venous insufficiency is that it's hereditary. It does fall in families. Obesity is another common cause of increase, as well as some people believe that standing for long periods of time or sitting for long periods of time causes
Teachers, people in retail profession, and hairdressers.
Right. I'm not so sure that that actually causes the disease as much as it makes the symptoms worse. The people probably have the underlying disease and they have that job, and it makes the symptoms worse and they notice it.
Now, let's go into the what different treatment options. It's like from the beginning.
Okay. So historically, like I said before, the venous insufficiency was treated conservatively with conservative treatments such as elevating your legs, walking, exercise, wearing compression stockings, the wonderful compression stockings that everybody hates.
Oh my gosh.
So that's kind of the conservative treatment. Sometimes people can take pain medication such as Advil or Tylenol. But as far as the more aggressive treatments go, historically it was treated surgically, and they would physically go in and strip these veins out. It was a procedure that was relatively painful and had to be done under general anesthesia, and the recovery time was significant. Usually they would get out of the hospital within a day or so, but it might take up to 6 weeks for their leg to heal. The patients were usually immobilized because of the pain that they had. And then, as we talked about earlier, in the early 2000s, the ability to treat these veins endovascularly, which means inside the vein, came to the United States. And the two major treatment options for that are either radiofrequency ablation or laser ablation of the veins. And then, in addition to that, there's a treatment called sclerotherapy, which is where we actually inject a chemical or a drug into the vein and closes the vein from the inside. And most people might be familiar with sclerotherapy to treat the small spider veins on the surface of the skin that you might have done at a dermatologist's office. Or, and they've been doing that with saline in the United States for a long period of time. Now there are FDA-approved drugs in the United States that we use to do that. But the sclerotherapy is also used to treat the medium size or the varicose veins that you see bulging out in people's legs as well.
What causes the bulge?
Well, the bulge is caused because the pressure inside that vein changes. And the reason why it changes is that the valves that connect the superficial venous system, which is where we have venous insufficiency, they connect to the deep system, and those valves break. And in women, sometimes those valves break during pregnancy, and then sometimes they just break over time. That's why we don't see this as often in younger people as older people. And when those valves break, the blood starts flowing the wrong direction in those superficial veins, and the pressure changes in those superficial veins, and so they start to dilate. And when they dilate and they're close enough to the surface of the skin, you'll start to see them. And for some people, these veins first start to dilate and show up after their first pregnancy, and then it just gets worse and worse over the next 10, 15 years. And for other people, you just wake up one day and you notice that it's there.
Now, what results can a patient expect having treatment for varicose veins?
The large varicose veins are really easy to take care of, and cosmetically you should expect a very good result. Basically, you won't see those veins anymore. Symptomatically, your legs really should start to improve the way they feel within a couple days of the treatment. It's amazing how many people have the treatment and they actually come in because they see the cosmetic varicose vein, and that's kind of why they're coming to see you. And you treat them, and their legs feel so much better. They tell you, my legs haven't felt this good in 10 years. I should have done this 10 years ago.
So they feel lighter. They don't feel as
Absolutely.
heavy.
They feel lighter. They swell less during the day. They cramp less. Some people complain of itching and burning that typically goes away. So there's a whole host of symptoms that can cause pain from this.
Do they come back, the veins?
Well, no matter what we do, it doesn't completely solve the problem, because the real problem is the broken valves, and we're just fixing the veins that break after the valves break. So most likely people will have some slight recurrence throughout their life. Usually it's a couple years later before they see something else. And often they never really see a problem again. They just notice that my legs are starting to get heavy again. And typically we just do another ultrasound, reevaluate their legs, and typically there is a few more veins there that need to be closed. You have about 25 miles of these superficial veins in your legs, and so the part that's abnormal is 10, 15 yards. So the vast majority of these veins are completely normal. However, we close that 10 yards of vein, and you still have 25 miles minus the 10 yards left. Some of those other veins are probably going to go bad at some point.
Now, is everybody an ideal patient? Or would you not want to do any type of vein therapy
I would
on,
say
or,
that
or limited amount?
The biggest contraindication is a patient that either had severe clotting disorders, where they had a very difficult time keeping their blood from clotting.
Or they're on some type of anticoagulant?
Correct.
Right.
Or patients that can't ambulate, people that are restricted to a wheelchair, something like that. And the reason is that the leg muscles actually compress the veins and force the blood against gravity to go back to your heart, so it can get cleaned out. And when you can't move, you no longer have that calf pump to actually pump the blood back against gravity. It's a problem we don't really have in our upper extremities because our arms are above our heart, so gravity doesn't work against us that way. But people that can't move very well have a higher risk of having complications from the procedure.
How often would you have to exercise or walk after a treatment?
I usually tell people that immediately after treatment they need to be moving at least 1 minute out of every 30 minutes throughout the day. And again, that's so that you're not sitting still for a long period of time without moving. There's no real requirement that you have to go for a 10-mile walk immediately afterwards or anything like that. But it is important that you stay active. And activity means any activity where your ankle's moving, because that compresses your calf and keeps the blood moving out of your legs.
Okay. What if people have a very sedentary job where they kind of just, should they be exercising? Should they be just sitting at their desk doing something? Rotation of some type?
I usually tell patients to set the timer on their cell phone. Almost everybody has an egg timer on their cell phone these days. And to set it for 30 minutes. And when it goes off, to reach over there and turn it off and think, have I been up for 1 minute in the last 30 minutes? And if they haven't been, to get up and move around a little bit, get a drink of water, or even just get up and walk around your chair for a minute. That keeps the blood moving and helps push that blood out of your legs. Very similarly to the exercises that you hear people talk about, well, I'm going on a long plane flight.
Right.
It's a very similar kind of exercise that you need to do. Movement of your ankle to contract your calves to keep the blood moving out of your leg.
You know, going back to the plane flights, I mean, it's not, I think people think of it as only like international, that they're flying to, but, you know, I just came from a flight, it was like 4.5 hours,
Right.
you know, coast to coast basically, and I was like a little sardine, and I didn't want to really bother the people. And then by about 4 hours, I was feeling this pain
Right.
coming up, my leg.
Right.
So you really should then get up and exercise.
That's correct. So the plane flight, the reason why everybody says move is because they worry about getting a DVT on
Right.
the plane, which is obviously a really bad thing to get. But what happens to almost everybody when you're on a long plane flight and you're sitting in a small space and you're not moving your legs is that you get to where you're going and you're tired, your legs are tired. Like you said, your legs started to cramp. And the reason for that is the blood is not coming out of your legs properly. And when that happens, the metabolites, mainly carbon dioxide, builds up in your legs, and that causes cramping. It's a very similar problem that occurs when you exercise, like run a marathon. Why people are sore the next day is because the metabolites build up in your muscles because you've overwhelmed your body's ability to clean the blood out efficiently by exercising so intensely. And it's a very similar process, but you do it without exercise, by just sitting still.
Okay.
So that activity is really important.
Activity is important. How about drinking water? Does that help too?
Drinking water is excellent. Staying hydrated. The other thing on an airplane is probably not drinking alcohol, although a lot of people like to do that, but that dehydrates you. The other thing that dehydrates you on an airplane is that the air that they're pumping into the airplane has no water in it. It's almost 0% humidity. And so you breathe that air in and you have to exhale that air at 100% humidity. And so you lose water every time you breathe on an airplane. So that's why it's very important to stay well hydrated on an airplane and move around.
Very good. So also let me know, because I know you are on the leading cutting edge of all new therapies and technology, and you do a lot of CMEs to physicians throughout the country. What is on the horizon? Should people wait? I mean, is there going to be something like in 2018 that's going to be a new type of therapy?
I don't think there's going to be a therapy in 2018 that's going to be better than what we currently have. Most of the therapies that are coming out that are competing with what we're currently using are focusing on trying to allow the procedure to be done a little bit easier with a little less discomfort. And the procedure now is not that uncomfortable, but it's not completely pain-free. There are limitations to those procedures. Probably my favorite one is glue, where you're actually going to just go in there and put a catheter inside the vein and put some glue in there, and the glue will close the vein. The problem with that is that they haven't developed a glue that dissolves yet, and so then the glue stays in there permanently. And so who knows what the body's reaction will be to the glue.
And what type of glue is it? I mean, what
it's basically crazy glue.
Oh my.
Yeah. So to me, that's the biggest problem if I was a 50-year-old, which I am, person that was having this done, would be that do I really want to have that glue inside my body for another 30 years? And I don't know the answer to that, but we've seen a lot of stuff in medicine where different devices have been put in people, and 10 years later they're saying, oh, you need to take that back out.
Right, there were certain hips and joints and...
Exactly. You just have to drive down the highway.
And meshes, a lot of
exactly,
meshes.
Look at the meshes.
Yes.
So if you had to have the mesh put in, you had to have it put in.
Right.
So that's great. Maybe you don't second guess yourself, but varicose vein disease for most people is not a life-threatening thing.
Right.
And so I think you want to choose a conservative treatment that has very little potential for a problem 30 or 40 years later. Although some of the patients we treat are in their 70s and 80s, most of the people we treat are in their 40s and their 50s. So they're going to live a very long time, and in my opinion, you want to be as safe as you can.
No, absolutely. Now, what would be the side effects of just having like any initial treatment?
So all the treatments require us to stick a needle into a vein, so you probably will have some bruising associated with that. Occasionally, probably the biggest thing that we worry about is somebody actually getting a blood clot because of the treatment. We're very careful to try to keep that from happening, but it does happen, less than 1% of the time, but that's not zero. So, but kind of the things that I expect most people to have is some very mild pain and bruising that usually starts getting better after about a day. Most people don't miss work. Probably one of the biggest hassles of the treatment is that we can't do it all in one day. It does require multiple visits. But by doing that, we also keep the pain level down and we keep the disruption to your life down. I've had plenty of patients that come in and see me in the morning and go work a 12-hour shift that same day. So it's not uncommon at all for somebody to work the same day of the procedure.
Very good. Alrighty. We have some slides because I think we covered a lot of the material we initially wanted to. Unless there's something you think our viewers should be aware of or something that you wanted to add?
No, not really.
Okay.
I'm happy to go through the slides with you.
Alrighty, let's go through the slides so we can pretty much where we started out. The cost of the CVI.
So venous insufficiency has a cost to our society. There are millions of Americans that I think the slide says there's 500,000 Americans that have the disease at any given time. And like all diseases, cardiovascular insufficiency has a cost to society through missed work and all of those.
All of those things. Right. Okay, let's go on to the next one, please.
This slide actually just shows that there are multiple types of veins in our body. Specifically in the legs, there's the deep venous system, which run with the muscle. And the reason why they're allowed the blood to get pumped back to the heart is because they're next to the muscle, and the muscle contracts those veins. I like to call those the highway veins.
Okay.
Most of the veins in your leg are the superficial veins, and they're more close to the skin. And those veins don't have that tissue around them to compress them, and so they rely on the pressure changes in the deep system to pull the blood into the deep system. And it's the valves between those two systems that break that cause the reflux and the veins to dilate, like we talked about earlier.
How about, do marathon runners have a lot of problems with their veins?
Marathon runners, I don't know if there's a specific problem with that. Certainly taller people have a problem with it.
Really?
Mainly because it's just you have more legs.
More legs.
And more gravity.
Alrighty. And the next slide, please. Okay.
This is just a diagram of the deep system and the superficial system, and there is it's important to know the difference. The people that get blood clots in the deep system, those are the ones that are really dangerous, and the superficial system is really what we're working on. We don't really do any treatment on the deep system at all.
Okay, very good. All right, and next slide, please. Okay.
This is a slide that's just talking about the muscular pump that we talked about earlier, with that the calf muscle is really responsible and has to be active in order to pump that blood back, and that's why people get in trouble on an airplane. It's why people get in trouble with a knee replacement or a hip replacement where they can't move their leg and the blood doesn't move, and so it solidifies and makes a clot.
That's unfortunate, yes. Okay, next slide, please. And that's the symptoms, right?
Right. So, I think one of the main things that people don't understand is that they think this is simply a cosmetic problem, and they don't realize that it can be the cause of their aching and pain and burning and itching in their legs, cramping. A lot of people complain of cramping, and a lot of people complain of swelling.
How about restless leg syndrome?
Restless leg syndrome can very much be caused by vein disease. It's very difficult to tell exactly what's causing restless leg syndrome. You can have a neurological cause for it, but certainly a lot of people that suffer from restless leg do have vein disease, and that's a major contributor.
Interesting factor. Next slide, please.
So when a patient comes in to see us, obviously it's very important that we do a complete history and physical, and find out whether if there's a genetic component to this, and make sure that there aren't any possible complications or cross-reactivity with medications they're taking, and things like that. So that's certainly the first part of any kind of consultation that we do.
Very good. Well, you want a complete detailed history,
Exactly.
and you're then take ultrasounds or take...
Exactly. So the second step is usually to create an ultrasound map of the veins to determine which treatment modality works best for that particular vein. And then, of course, we always have to deal with the insurance companies. So we write all that up into a letter and send that to the insurance companies. The insurance covers this the vast majority of the time. Probably 90+% of the patients we treat have coverage through their insurance.
Well, it's good that they recognize that,
Right.
you know, it is...
Including Medicare.
Oh, okay. Very good. Very good. Next slide, please.
This slide just kind of outlines the classification system for venous disease. Some people might just have only a few spider veins in their legs. And at the other end of the spectrum, the vein disease can actually start to damage the skin and cause ulcers and a variety of dermatitis and things like that.
Now, once that does appear, can that go away, or does the discoloration stay?
Usually, the discoloration sometimes will fade. Once somebody has an ulcer, you're probably going to end up with a permanent scar there, but it's important to get the ulcer closed. The ulcer itself can be a nidus for infection and cellulitis.
Oh, absolutely.
And so, but typically once somebody starts to get severe staining on their legs, that's a permanent problem.
But if you take care of it before it gets to that degree,
Then you should never develop those.
then you should never develop
Correct.
it, right? Okay,
Correct.
that was my next question, yes. And next slide, please.
And this is just a slide kind of showing a hand-drawn map that we create with the ultrasound machine that kind of shows us which veins are refluxing and allows us to decide which veins we're going to treat with an ablation catheter and which veins we're going to treat with sclerotherapy.
Now, do you do one leg and then do the other leg at another time, or how does
We
it work?
usually do one leg in one day. Again, we're trying to limit the amount of discomfort that you have. But we get it all overlapping so that the whole treatment on both legs is done over a period of a couple weeks.
Oh, okay, that's a very short time.
It is.
Okay, yes, very good. Next slide, please. I think we're almost done. So, already, and we have here.
Yeah, this is just an ultrasound image showing the showing venous insufficiency. It's that the blood's actually flowing the wrong direction. in the
Okay,
vein.
yes. And next slide, please.
And this just discusses the treatment options that we've talked about, starting with the most conservative treatments, the wearing compression stockings and staying active.
Right. Elevation. Right.
Exactly.
Next slide, please. More treatment options.
Yeah, that's just a continuation.
Okay, next slide, please.
I think this is an actual patient, and you can see
Oh, yes,
from the
it is, a
pictures
case study.
the very red ankle and large bulging varicose veins, and how those bulging veins correlate with the red lines on the schematic drawing there around the calf area. I think the next slide's going to
Okay,
show us
next slide,
post-treatment.
Yes. There we go.
And you can see that the leg is healed significantly since then. There's still some scarring there, but you don't see those bulging varicose
No,
veins
you
anymore.
do. Yeah.
And I think more importantly, the patient's leg felt so much better.
Oh,
Pain had gone
sure,
away, itching and
right.
burning.
Now, is that a man's leg, or?
I think that was a woman's
It was a woman's leg. Okay. Case study. Okay. I think is another side, or that's it?
That's
I think that's
probably
it.
the last
There we
slide,
go. Okay. So tell me about, we were talking about for 2018, everything is about the same,
Everything's
except for the
about
glue.
the same for 2018. There are a couple technologies that got FDA approved in the last year or so, but none of those technologies as of July were actually being paid for by insurance companies yet. They're still considered investigational by insurance companies.
Okay, so when this term is investigational, that means that
Means they're not going to cover.
right.
paying
So
for
it would the person would have to do a self-pay.
That's
if
correct.
It is something they
if
want
they
to.
wanted to do one of those other
Right.
treatment modalities.
Right.
Which I don't think they're quite there yet as far as being directly compatible with the tools that we currently have. But hopefully something will come in the future.
Well, I thank you so much, Dr. Humphrey. This has been so informative about varicose veins, and you're just a wealth of information to do that, and all the slides in your presentation today. I hope we can invite you back one day.
Oh, you're most welcome.
Yes.
And I appreciate you.